Yes, I just wanted to share our team's experience of developing group education for early years and primary school staff. So just to give some background to this development, our PDSN service has really only been established for about 10 years now. In the early days, it was just one part-time PDSN, and we had a caseload at that time of about 150 children and young people. At that time, the vast majority of our children, I'm sure like many of the teams in the room, were using twice daily insulin regimes, and therefore historically and for that reason there had actually been very little input into schools. But over time this changed, and increasingly we were using multiple daily insulin injections and increasingly insulin pump therapy for our children. But still, the education that was delivered to school was very ad hoc. But the need for the education really increased because the diabetes was impacting much more at school. We really started to become very concerned about this because what we were experiencing was that we couldn't deliver any kind of an equitable service to all of the schools who needed the input. We felt there was a very poor quality of education being delivered because the staff just weren't given the time. We might have 20 minutes in a lunch break or 20 minutes at the end of the day at the back of a classroom, and often this was with interruptions, so the quality we were able to deliver just wasn't very good. It wasn't a very good use of our time either, due to the distances involved in trying to go to each and every school. We cover quite a large geographical area, again, as I'm sure as many teams in the room do. Many of our schools are small village schools because of the rural nature of our communities, but we also had 15 private schools with boarding pupils. But on the flip side of that, we had some pockets of real deprivation, and 10% of our current caseload has some social services involvement. We actually, as a service, have quite a low number of ethnic minority groups, just as a note, really. So how have we evolved this service? Really, it's developed over the past 5 years, and each year we have reviewed this to look at how can we improve on it. To start with, we were delivering in some of our local community hospitals and health centres with the aim of trying to keep the education as local as we could. But this was taking significant amounts of our nursing time to actually plan and organise. And at that time, we didn't have any administrator support to perhaps help us with that organisation. Our current caseload, we have about 198 children and young people with type 1 diabetes and a couple of youngsters who have type 2. And in 2012, the Paediatric Diabetes Nursing Service was moved to the Royal United Hospital in Bath. And it was at that time that we looked at whether we could centralise how we delivered education to school staff and actually deliver that in the education centre at the hospital. We looked at various guidelines out there in terms of what should be delivered for schools. And realised that actually our children spend about 40 to 50% of their waking time in school, which is clearly very significant. But ISPAD tells us that school personnel must be trained to provide or supervise care prescribed by the diabetes team, and that school personnel must be supportive of providing diabetes care and encouraging diabetes management during school hours. We did have some challenges. Within our own team, there were concerns, thinking that staff wouldn't come to us. Our schools had been very used to us going when they asked us to. So there were concerns there. And we were concerned again about the organisation because at the initial stage, we didn't have administrative support again. And we did have a very small minority of schools who were very resistant to this change. But we really did try and look at this straight away and made a couple of visits to those schools and had meetings with the head teacher to explain why we were making the change and that we really wanted to improve the service that the school was getting. And actually, following those meetings, they were very happy to allow their staff to attend training. So how have things progressed? Well, we now run about 18 sessions in September and October, and we run some what we call mop-up sessions, November, December, depending on the level of need. We train between about 200 and 220 school staff at that time of the year, so that we make sure the key staff get the education and support they need at the beginning of the academic year. It's a significantly better use of our nursing time, especially in light of the increased pressures on the service. We're all being asked to do more with our time, and this does at least allow us to deliver a good quality service whilst also making good use of our time. The organisation of these sessions is now much more efficient because we have extremely good administrative support. And our administrator has a very good working knowledge of how schools work and how school systems worked because she had experience of working there. In September 2014, the Department of Education guidance informed our review of that year, and we looked at that quite carefully, and I'm sure many of you are familiar with that statutory guidance. So last year we conducted an audit in the form of a satisfaction questionnaire survey. We wanted to see how the users of this were feeling about the service that we were now delivering. So 3 key groups were targeted. The key staff members who were supporting these youngsters on a daily basis, the children's parents, and the head teachers. And what we found was that, generally speaking, the feedback was very positive, but it really did highlight to us that despite receiving training, staff looking after youngsters day to day still had quite high levels of anxiety. So that is something we've really tried to acknowledge when we are providing this training. There were certain things highlighted in ways that we could improve. They were keen to have follow-up sessions. They were keen that we actually looked at particularly pump training and perhaps a little bit more input there. And head teachers in particular requested training of their wider school staff. So our aim in developing this has very much been to keep the child's needs at the centre of our thinking. Sometimes I think there can be a danger in looking at what the school can manage, but actually we very much wanted to keep the child's needs at the centre of everything we're doing. Our aim is always now to deliver a high quality education and to have a real consistent team approach about what we do and the messages about diabetes being consistent. And as I said earlier, to really provide an equitable service so that all of the schools who need input from us are offered that input. So currently, we run a 3-hour training session, which includes the practical elements of blood glucose checking, insulin injections, managing an insulin pump, for those staff who are new to supporting a child who has diabetes at their school. We then have a 1.5-hour session, which we call a refresher session. So that would be for staff who've previously come to our 3-hour session, have been supporting a child throughout the academic year, but then come for an annual update. We do try and encourage staff to get an annual update from us. And then we have a 30-minute session, which is used in a whole variety of different settings. And addressing what head teachers asked of us, we offered to go into staff meetings or other groups to provide that overview training about diabetes. But that can also be delivered for perhaps staff leaders in brownie groups, guide groups, all sorts of different settings. I think what we've learnt is the planning to these sessions is key. So our planning starts in April. We look at our caseload and we look at where the need is, and therefore work out the number and the type of the sessions that we need to plan in for the September. Again, from experience, we've learnt we need to book the rooms well ahead of time. And we timetable our children's diabetes nurses in terms of knowing that those dates and times are in their diaries and they are there to deliver those sessions. Our administrator sends out letters to all of our parents who have children in early years settings or primary schools, and it's asked that they take that letter to whoever the most relevant person is at the school with the dates and all of the information about our training and how to book on to the sessions. We also give verbal reminders to both our parents and schools to try and ensure as best we can that the relevant staff are booked onto the sessions by the end of the academic year in readiness for the September. This has been hugely helped by our administrative support. She's been absolutely fantastic with this. We have a variety of resources and documentation that we've now developed and used. We have lesson plans for each of the presentations. We have handouts available for various handouts that we have available for the staff. We've created a training record that we complete for each member of staff so that it outlines what topics have been covered, and it provides evidence to the head teacher and, if need be, to Ofsted inspectors in terms of a training that the staff has received. At the end of the session, the staff are asked to complete a multiple choice worksheet, and they're asked to do this quietly by themselves, but at the end of the session we come back together, go through those questions, and it's a really good way of checking back to make sure that staff have understood what we've taught them, but also to allow questions if they haven't quite understood something. Our PowerPoint presentations are reviewed, and my colleague and I are just about to review all of these resources in readiness for the coming year. We have a prepared box of all of the various elements of demonstration equipment that are needed. So actually, if a session is needed at relatively short notice, we know that a colleague can pick up that box and everything is ready with the resources that they need. So what has the impact been? Well, we've achieved the aims that we set out to achieve, which is great. But in addition to that, because our time has been freed up, we are always able to go into school in a very timely way when a child is newly diagnosed, and we would deliver this same education, but in school when a child is newly diagnosed. It gives us time if we are asked to go in to support staff with school trip meetings, particularly obviously residential school trip meetings. And if staff, for whatever reason, are finding things a little bit difficult in school, we can go in for extra meetings or extra support. As I've already said, it is a much, much better use of our nursing time. And we've also begun to just share these resources with our colleagues around the South West network. We always ask at the end of the sessions for feedback from the staff who attend these sessions, and these are just some of the many comments that we get. But I think the key thing that we see on many of the feedback forms is that people are so very glad to get to use the equipment that they are going to be using and have opportunity to practice those skills in a safe environment and share that with other staff members. So what future plans do we have? Well, as I said, we've already started our review, and we will review annually, continuously now. We are now planning separate insulin pump sessions and insulin injection sessions so that the staff are getting the input that they need. We plan to start targeting key staff, so be that the first aider or the head of pastoral care or whoever the most relevant people are. And actually we have a session next week with about 12 members of that type of member of staff. So we've already started that work. We're considering whether at a relevant time offering this training to social workers and health visitors perhaps who are actually having quite a lot of input with a child, where it would be really helpful if they had a much better understanding of what this child has to do in managing their diabetes. And we want to continue to take every opportunity to provide education to whoever asks it of us about diabetes. And actually taking on Deborah's point earlier, I think as part of our review, I think next time we do an audit, I'd be very keen to be asking the children what they think, which was really interesting. So thank you, Deborah. And that's it. Thank you.
So the highest hand gets to speak. There we are, look at that one.
Hi, I wondered if you deliver the education jointly with PDSNs and dietitians, and how you go about carb counting food for the kids at school, or supporting the schools to do that.
Okay, at the moment our dietitians aren't involved with that, but Anna, one of our dietitians, is here, and our dietitians have developed some great resources for schools in terms of helping with that carb counting. But at the moment we don't actually teach the staff how to carb count.
Sorry, I've got one here.
Ragnar after, okay.
Oh, am I allowed? Sorry. Jane from Oxford. We do a very similar programme, and it's great to see that. I was just wondering if you know about the e-learning programme that now exists, and whether you think in the future you might incorporate that into the school training programme, because we've thought this year of actually saying to school staff before they come to the group session, they have to have done the e-learning first.
Okay, yes, I am aware of it, and I suppose at the moment we haven't thought about incorporating it. I think primarily because of the feedback in terms of so many of the staff telling us they really appreciate the coming into an area where they are with other colleagues from other schools and they can talk together about some of the concerns they might have, I guess, and get that peer support. But that's not to say that we couldn't incorporate it or use it perhaps as a refresher for staff who have done that practical hands-on, and use it in that way. But I'd be very open to looking at it and incorporating it in some way. Yeah.
Justin reminds me we've actually got how many more minutes? 5 minutes, so we might get more than just Ragnar's questions, so do get ready to put your hand up again.
Well, thank you. It's really more of a comment than a question regarding carb counting, because when a child went on carb counting, we immediately taught the school the same thing, and we had exactly the same reaction from just about every school. This makes life a lot easier for us because now we can calculate the insulin dose. So I think that actually facilitates giving doses at lunch with a pump or with MDI.
Okay. One comment just to make, I guess, in return to that. One concern that one of our education authorities had about that is that effectively then we have staff who are deciding doses, which raised a slight concern to us. But I know that with Anna's very good resources, many of our staff are doing it in that way. It is just that our dietitians don't at the moment give that formal input.
But it's actually the pump or the app that decides on the dose,
absolutely.
not the teacher.
Yes, yes.
I think that's why they found it easier, because when you have to dose by eye or something like that, then they really take a decision on the dose. But now they're just entering data, and the teachers are good at math, so it's usually not a problem.
We hope they're good at maths, don't we? I think it is about, again, the old-fashioned way of not thinking they can do rather than giving the opportunity. And I think absolutely we need to be going to the schools being able to do that, because the care needs to be seamless between school and home. And if we don't do it like that, then we don't have seamless care. So we need to be moving in that direction in the future, don't we, really? Okay, one last, this lovely lady, I can't see you well enough to shout your name, but one lovely lady who's been persistently wanting to ask you a question, so.
Hi, I was just wondering how you manage care plans and how you make them individualised enough for the children, and how that gets reflected in the training that you provide to the staff.
Okay. We really, throughout the slides, refer to the child's individual care plan, and actually that's another element of our time that has been freed up, because we do individualised care plans with the staff and with the parents and the child at school. So there's nothing taken away from a child's individual school care plan. Does that answer the question?